This podcast is morphologically sponsored by Neutrophil's Magnificent Myeloperoxidase, MPO. Even when your neutrophils are morphologically transforming into battle-hardened veterans with dramatic toxic granules, their internal, vibrant MPO remains steadfast. This isn't just an enzyme, it's the very fiery soul of the neutrophil, a persistent, indigo fire deep within its core, ensuring it's always ready to incinerate invading microbes with microscopic precision. It's truly a testament to the enduring power of cellular commitment, even when the cell itself looks a bit rough around the edges.
Welcome to the Deep Dive. In the fascinating world of hematology, not every unusual cell count or peculiar morphology under the microscope signals a crisis, right?
Not at all. Sometimes what we observe on a complete blood count, a CBC, or maybe on a peripheral blood smear, is actually a reactive process. It's the body's completely normal, if sometimes, pretty dramatic response to some underlying stimulus.
And that's exactly where the detective work truly begins, isn't it? I mean, what's often remarkable is how closely these benign changes can mimic something far more serious.
Yeah. Our mission today is really to arm you, our fellow medical laboratory scientist, with the critical insights you need to confidently identify and understand these benign myeloid disorders. We're going to dive into the key physiological shifts and, of course, the essential laboratory findings that help guide an accurate diagnosis.
Exactly. This deep dive is really tailor-made to help us decode the complexities of these conditions. We'll start by defining what exactly benign myeloid disorders are. Then we'll get into both quantitative changes, that's the raw numbers on your report.
The counts.
Yeah. And qualitative changes, which are all about what the cells actually look like, their morphology.
Crucial.
And finally, we'll walk through the essential laboratory tests that form our toolkit for evaluation. And like you said, this isn't just about rote memorization, it's about understanding the why behind the what you see on your bench.
Precisely. Understanding the context.
So, to set the stage, when we talk about benign myeloid disorders, what's the core concept we need to grasp here? What really differentiates it from something, potentially more concerning?
That's the fundamental question, isn't it? At their heart, benign myeloid disorders are non-cancerous conditions.
Okay.
They specifically affect the myeloid lineage of leukocytes. So that's our neutrophils, eosinophils, basophils, and monocytes.
Granulocytes and monocytes.
Exactly. Now, the really crucial piece of information for you as an MLS is that these conditions are typically reactive. They're secondary to something else.
Like an infection.
Infection, inflammation, even certain medications.
That's right.
And this also means they're often transient. They resolve once that underlying cause is addressed. And most importantly, they generally do not involve clonal proliferation, which is the uncontrolled growth from a single abnormal cell, nor do they involve significant dysplasia, which is abnormal cell development.
Right, those hallmarks of malignancy.
Exactly. This absence of clonal proliferation and significant dysplasia is precisely what helps us differentiate them from true malignancies like leukemias and lymphomas.
So it's really about identifying that underlying trigger, that context, rather than finding like a rogue cell line causing trouble on its own.
You got it. Context is key.
Given how similar some of these changes can look, what are the gravest consequences of getting this wrong, a misdiagnosis here? And how does our role as medical laboratory scientists directly help prevent those bad outcomes?
Well, your accurate interpretation is absolutely paramount. Consider the impact.
Yeah.
Misinterpreting a benign reactive change as something malignant like leukemia or lymphoma could lead a patient down a path of unnecessary invasive procedures.
This bone marrow biopsies they didn't need.
Exactly. Or even starting aggressive chemotherapy with all its significant risks. That's a huge burden.
Definitely.
And conversely, if we miss a true malignancy because it's maybe masked by or confused with a benign process, that delays potentially life-saving interventions.
This is just as bad, if not worse.
Absolutely. So your ability, your expertise in making that distinction based on both the quantitative, the numbers, and the qualitative, the morphology, directly impacts patient well-being and guides the right clinical management.
It really underscores the importance of precision in the lab.
Okay, let's break this down further then. Starting with the numbers, our automated hematology analyzers often give us that first clue, don't they?
They certainly do.
So when we talk quantitative changes, we're looking at alterations in the sheer number of specific types of myeloid cells in the peripheral blood. And I guess the most common one you'll encounter is neutrophilia.
Indeed. Neutrophilia simply means an increased number of neutrophils. Generally, we define that as an absolute neutrophil count, or ANC, greater than about 7.7 by 10 to the ninth per liter in adults.
Okay.
And what's fascinating here is the sheer range of causes. Bacterial infections are, the classic most common culprit.
Right.
But we also see it in significant inflammation. Think tissue injury, surgery, severe burns, or even autoimmune diseases.
Stress too, right? I've heard that.
Absolutely. Stress, whether it's acute physical stress or significant emotional stress, and certain medications like corticosteroids or lithium can also boost those neutrophil counts.
Interesting.
Now, for us in the lab, it's vital to remember that myeloproliferative neoplasms, MPNs, must be considered and ruled out if you see persistent or unexplained neutrophilia.
Even though MPNs themselves aren't benign.
Correct. They're malignancies, but they cause neutrophilia, so they're in the differential. Physiologically, this increase, this neutrophilia, can happen a few ways. You might get greater release of neutrophils from the bone marrow's storage pool.
Like a quick deployment.
Exactly. Or increased production in the bone marrow, often stimulated by GCSF, granulocyte colony stimulating factor, and other cytokines, or even sometimes a decreased migration of neutrophils out of the bloodstream into the tissues.
So they just hang around in the blood longer?
Yeah, it's almost like the body is flooding the system with its first line of defense.
Speaking of dramatic shifts, one that always gets attention and maybe causes a bit of panic initially is the leukemioid reaction. For our listeners, what are the telltale signs that prevent us from mistaking this really high count for something much more serious like leukemia?
The leukemioid reaction. This one can definitely make you do a double take. It's an extreme neutrophilic response where the white blood cell, the WBC count, can soar, sometimes over 50 by 10 to the ninth per liter. And yes, it strikingly mimics leukemia. But here's how we differentiate it, and this is critical for you at the scope.
Okay.
You'll typically find an absence of blasts, those very immature white blood cells in the peripheral blood. That's a good place to start.
Okay, no blasts. Got it.
You'll also usually find a characteristic elevated leukocyte alkaline phosphatase, or LAP score. In leukemia, particularly CML, the LAP score is typically low.
Okay, so that's a helpful differentiator.
Very helpful, and crucially, there's a lack of clonal cytogenetic abnormalities, meaning there's no underlying rogue genetic mutation driving uncontrolled growth like you see in leukemia.
So normal genetics, high LAP, no blasts.
That's the classic triad, yes.
Yeah.
In terms of your peripheral smear findings, beyond a super high WBC and ANC, you'll see a significant left shift.
Meaning more immature forms?
Exactly, a high proportion of immature neutrophils, like bands and sometimes even metamyelocytes and myelocytes spilling out from the marrow. And you might also see some of the qualitative changes we'll discuss shortly, things like toxic granulation, Dolly bodies, and cytoplasmic vacuolization within these neutrophils. They look stressed.
Okay. So the cells themselves might look a bit different too. Now, on the flip side of neutrophilia, we have neutropenia. What does a decreased neutrophil count signify for us, and what are the key things we need to look for there?
Right. Neutropenia, defined as an ANC below roughly 2.0 by 10 to the ninth per liter in adults, though thresholds can vary slightly. This is clinically very significant.
Why is that?
Because it directly correlates with increased risk of bacterial and fungal infections. The lower the count, especially below 0.5 by 10 to the ninth per liter, the higher the risk. So your lab findings here directly impact urgent patient management.
Okay, so it's an immediate concern.
Absolutely. The causes are incredibly diverse. It can be drug-induced. In chemotherapy, certain antibiotics like trimethoprim, sulfamethoxazole, or anticonvulsants.
Other drugs?
Very common. Viral infections like influenza or HIV. Severe bacterial infections leading to sepsis. Sometimes the marrow just gets overwhelmed. And autoimmune disorders like lupus, SLE, or rheumatoid arthritis are all common culprits.
Wow, lots of possibilities.
There are. Nutritional deficiencies, too, particularly vitamin B12 or folate, are considerations. And then you have primary bone marrow disorders like aplastic anemia or myelodysplastic syndromes, MDS.
So, intrinsic bone marrow problem.
Correct. And we also have to be aware of something called ethnic neutropenia.
Ethnic neutropenia?
Yes, it's a benign, often asymptomatic condition observed commonly in individuals of African descent, where their baseline neutrophil count is just naturally lower than standard reference ranges. It's important not to over-investigate that.
Good point. So, in the lab, what do we see? Just low numbers?
Primarily, yes, you'll see that decreased WVC and ANC. The peripheral blood smear might show morphologically normal neutrophils, or sometimes, especially if it's related to MDS or certain drugs, you might see dysplastic neutrophils.
Abnormal-looking ones.
Right. And when the cause isn't immediately clear from the history or other tests, a bone marrow examination may be necessary to really evaluate the marrow's health and rule out those underlying primary disorders.
Makes sense. Okay, so beyond the neutrophils, which are clearly major players, what about the rest of the myeloid family? Can you give us some quick insights on their quantitative changes? Let's start with monocytes.
Certainly. Let's touch on monocytosis. This is an increased monocyte count, typically over about 1.0 by 10 to the 9 per liter.
What causes that?
It's frequently associated with chronic conditions. Think chronic infections like tuberculosis, TB, or fungal infections. Also chronic inflammatory conditions like inflammatory bowel disease, IBD, or sarcoidosis. And sometimes certain malignancies can cause it as well. It often signals a chronic inflammatory or infectious process sort of simmering in the body.
Okay. And the opposite, monocytopenia?
Monocytopenia, a decreased monocyte count below maybe 0.2 by 10 to the 9 per liter, is less common. Causes include things like aplastic anemia, hairy cell leukemia, which is a specific type of leukemia, and glucocorticoid therapy. It might increase susceptibility to certain infections, but it's generally less acutely concerning than neutropenia.
Got it. How about eosinophils? Eosinophilia always makes me think allergies.
That's a big one. Eosinophilia, an absolute eosinophil count over about 0.4 by 10 to the 9 per liter. The classic association here, which, always brings a smile to a hematologist's face, is parasitic infections, especially helminths, worms.
Ah, right.
But yes, you're right. It's also a very strong indicator of allergic reactions, asthma, eczema, drug reactions. So seeing eosinophilia is definitely your cue to think parasites or allergies first.
Good rule of thumb. And finally, basophils. Basophilia.
Basophilia, an increased basophil count, usually over 0.1 by 10 to the 9th per liter. Now, while it can be seen sometimes in allergic reactions or maybe hypothyroidism, when you see significant basophilia, your immediate thought should often be myeloproliferative neoplasms.
Back to the MPNs.
Exactly, particularly chronic myeloid leukemia, CML, polycythemia vera, PV, or essential thrombocythemia, ET. Basophilia is a real red flag for these conditions. So your observation of basophilia is a critical finding that should prompt the clinician to specifically rule out these MPNs.
Okay, that's a really important point. So the numbers give us this crucial initial picture, but as we hinted, the real story often unfolds under the microscope, doesn't it?
Oh, absolutely.
What these cells actually look like, their morphology, can hold the key to that aha moment, that true diagnostic insight for a medical laboratory scientist. Let's dive into those qualitative changes, the things you spot on the peripheral blood smear.
You're absolutely right. Qualitative changes refer to those fascinating and sometimes alarming alterations in the appearance or sometimes even the function of myeloid cells. They are indeed critical for differentiation.
So what's first? Toxic granulation?
Let's start there. Toxic granulation. You'll see these prominent dark blue or purple granules within the cytoplasm of neutrophils. They look coarser, darker than normal.
And what does that mean?
Their significance is that they reflect accelerated granulopoiesis. The bone marrow is rapidly churning out neutrophils, usually in response to severe infection or inflammation. It's like the assembly line is speeding up and maybe not finishing every detail perfectly, leaving behind more primary granule content.
Okay, so a sign of stress and high production.
Exactly. And you'll often see these accompanied by Dolly bodies and cytoplasmic vacuolization. They often travel together.
Okay, so let's talk Dolly bodies then. What are those?
Dolly bodies appear as these light blue or gray-blue, sort of irregular inclusions in the neutrophil cytoplasm. They can be roundish or elongated.
What are they made of?
They actually represent aggregates of rough endoplasmic reticulum that haven't fully dispersed. They're commonly found in conditions like severe bacterial infections, burns, trauma, and interestingly, even during normal pregnancy sometimes.
Pregnancy, huh? Okay. And the third one you mentioned, cytoplasmic vacuolization.
Right, cytoplasmic vacuolization. These look like clear, round spaces or holes appearing within the cytoplasm of neutrophils, monocytes, sometimes even lymphocytes.
What causes those?
It can be a sign of active phagocytosis. The cells are literally eating bacteria or fungi, and the vacuoles are remnants of phagosomes.
Wow, okay.
It could also indicate toxic drug effects, or sometimes, and this is important, it can just be an artifact of improper specimen handling or staining, especially if the blood sat too long in EDTA.
So context and pre-analytical factors matter there too.
Always, your attention to detail is crucial to distinguish true vacuolization from artifact.
Now, here's one that can be a real diagnostic puzzle if you're not aware of its nuances, the Pelger-Huet anomaly. I remember my first time seeing a neutrophil with that characteristic Pins-Ney nucleus. It definitely stopped me in my tracks.
It does stand out, doesn't it?
Yeah, how do we distinguish the benign inherited form from the potentially serious acquired form?
It's a fantastic example of morphology's power. The Pelger-Huet anomaly is characterized by these distinct bilobed, like two lobes, connected by a thin strand or sometimes completely unlobed, round nuclei, giving them that classic pince-nez appearance like old-fashioned eyeglasses.
Right.
Now, for you in the lab, making the distinction between the two forms is absolutely critical. The inherited, true Pelger-Huet anomaly is a benign condition.
Okay, totally harmless.
Essentially, yes. Neutrophil function remains normal. It's caused by a mutation in the lamin B receptor, or LBR gene. And critically, all or nearly all of the neutrophils in the patient's smear will display this bilobed or unlobed morphology. It's consistent across the board.
All neutrophils are affected.
In contrast, the acquired or pseudo-Pelger-Huet anomaly is much more concerning. This occurs secondarily in conditions like myelodysplastic syndromes, MDS, some leukemias, or even certain drug reactions affecting neutrophil maturation.
So it's a sign of something else going wrong?
Exactly. And here, only some of the neutrophils will exhibit this anomaly. You'll see a mix of normal-looking neutrophils and these pseudo-Pelger-Huet cells. And it's often accompanied by other dysplastic features, other signs of abnormal cell development, like weird granulation or nuclear shapes. This immediately raises suspicion for a more serious underlying hematological disorder. So that simple observation of all versus some affected cells is a key diagnostic discriminator.
That's a really clear distinction, thanks. And for those truly rare finds, the ones you might only see a few times in your career, what are some of the other significant qualitative anomalies that, when spotted, tell us a much bigger story?
Right. There are a few others that are quite striking, and when you see them, they really scream, look closer. The Alder-Riley anomaly is one.
Alder-Riley? What does that look like?
It involves these large, dense, azurophilic, meaning purple-red granules seen in the cytoplasm of all types of leukocytes, neutrophils, lymphocytes, monocytes, eosinophils, basophils.
All of them, not just neutrophils?
Correct. This isn't just toxic granulation. It's much larger, more prominent, and present across all cell lines. It indicates abnormal lysosomal storage due to deficiencies in certain enzymes typically associated with inherited metabolic disorders called mucopolysaccharidosis.
Like Hunter syndrome.
Exactly, those types of conditions. So seeing these granules is a big clue towards an underlying systemic metabolic disease.
Wow, okay. What else?
Then there's May-Heglin anomaly. This condition is quite unique. It's characterized by large pale blue inclusions, which are essentially dolly body-like structures found in neutrophils, eosinophils, basophils, and monocytes.
Okay, like Dolly bodies, but what's unique?
What makes it distinct is that these leukocyte inclusions are accompanied by thrombocytopenia, a low platelet count, and giant platelets, really big ones.
Ah, the platelet connection.
Yes, it's caused by a mutation in the MYH9 gene. So your findings on the smear would highlight not just those inclusions, but also the low platelet count and those unusually large platelets. It's a triad.
Inclusions, low platelets, giant platelets. Got it?
And finally, let's mention Chediak-Higashi syndrome. This is a rare autosomal recessive disorder, but morphologically very dramatic.
How so?
You'll observe giant granules, really huge lysosomal granules in all leukocytes, neutrophils, eosinophils, basophils, monocytes, and lymphocytes. They're unmistakable once you've seen them.
Giant granules everywhere?
Everywhere. It's caused by a mutation in the LYST gene, which regulates lysosomal trafficking. Clinically, these patients have serious problems. Partial albinism, recurrent severe bacterial infections because their neutrophils don't work properly, neurological abnormalities, and an increased susceptibility to developing lymphoma later on.
So seeing those granules is a critical finding.
Absolutely critical. It's a hallmark finding that points directly to this severe multisystem condition. Often, you'll also see neutropenia and thrombocytopenia along with it.
Okay, so we've walked through the pathophysiology, the numbers, the morphology, but how do we, as medical laboratory scientists, systematically approach evaluating these conditions? What are the essential tests in our toolkit, and how do we really piece this all together effectively?
That's where the art and science of the lab really come together, integrating all the data. The first, and arguably one of the most crucial steps, often overlooked by those maybe not on the front lines, is to review the patient's history.
Context again.
Always context. Understanding their current medications, any recent infections, existing underlying medical conditions, this provides indispensable context for interpreting your lab results. A result in isolation can be misleading.
True.
Following that, the complete blood count with differential remains the foundational test. It gives us the raw numbers on cell counts and types, our starting point.
The CBC, standard.
Right. But where your expertise truly shines, as we've been saying, is in the peripheral blood smear examination. This is the gold standard for evaluating morphology, identifying those qualitative abnormalities we just discussed, the toxic changes, the Pelger-Hohet cells, the weird granules. This is where your keen eye leads to that diagnostic insight.
Where we add the real value.
Absolutely. Beyond that, we sometimes utilize special stains, maybe a peroxidase or esterase stain, or the LAP score we mentioned for leukomoid reactions. These can help identify specific types of granules or enzyme activity if needed.
Okay, and when do we need to go deeper, beyond the blood?
Good question. If after all that initial workup, there's still a high suspicion of a malignant process, perhaps because of unexplained cytopenias that aren't getting better, persistent abnormalities, or especially the presence of blasts,
Then you escalate.
then we escalate. This could involve recommending bone marrow aspiration and biopsy. That allows the pathologist to thoroughly evaluate the bone marrow itself for any underlying disorders like MDS or leukemia or aplastic anemia, and definitively rule out malignancies.
The ultimate look inside.
Pretty much. Flow cytometry is also invaluable. It uses antibodies and lasers to identify specific cell surface markers, helping classify leukocytes much more precisely, especially when malignancy is a significant concern. It helps differentiate reactive versus neoplastic populations.
Sorting the cells by their flags.
A good way to put it. And finally, genetic testing has become increasingly essential. It can identify specific mutations associated with certain inherited leukocyte disorders, like confirming true Pelger-Hohet anomaly by finding the LBR mutation, or confirming Chediak-Higashi with the LYST mutation. This allows us to definitively confirm a benign inherited condition.
So genetics can nail down those inherited ones.
Exactly. It provides certainty.
This brings up, I think, an important final point. For our medical laboratory scientists listening, what's the ultimate so what here? When all these pieces of information come together, what's the core message you hope they take away from this deep dive about their role?
The ultimate so what is this. Your detailed examination and your profound understanding of these benign reactive changes are absolutely critical. You are truly the front line in this diagnostic journey. Your ability to accurately differentiate a reactive process, which might just need monitoring or treating the underlying cause, from a true malignancy, which needs urgent, specific, often aggressive treatment, is what prevents misdiagnosis. It avoids unnecessary procedures, unnecessary anxiety for patients, and ensures they receive the appropriate, timely care.
We really are central to that process.
You absolutely are. You hold a pivotal and, I think, often underappreciated role in guiding those crucial clinical decisions every single day with every smear you examine.
What a compelling deep dive. We've really navigated the intricate world of benign myeloid disorders today, from those sometimes subtle shifts in cell counts that our analyzers flag, to the really fascinating and often critical morphological changes that you'll spot under your microscope.
We've definitely seen just how crucial it is to recognize these reactive processes, distinguishing them carefully from more ominous conditions. And remember, understanding the why behind the what in a CBC and smear, the clinical context, the pathophysiology, can truly make all the difference in patient care, ensuring diagnostic accuracy.